more first. Oh, what happened? All my windows. Okay. Yeah. Hi, everyone. It is a pleasure to introduce Dr. Lars Dyrskjøt as our QCRI seminar speaker today. I'm sure people in the field of bladder cancer know Dr. Dyrskjøt and his contributions that have significantly advanced to our current understanding of molecular features of bladder tumors. Dr. Dyrskjøt is a professor and group leader in the Department of Molecular Medicine at Aarhus University, Denmark. He also serves as a director and steering group chairman for the tdDNA DCC Research Center, and as a co-PI and steering group member for the Tombola trial, in which detection of tumor DNA in the blood is being evaluated to identify patients with early signs of metastatic disease following PD-L1 immune checkpoint blockade treatment. Dr. Dyrskjøt is very accomplished, as many of you know, and he has received several awards for his leadership and scientific contributions. The most publishing researcher below age 40 awarded by Aarhus University Hospital stands out to me as he has kept this trend going. Last couple of weeks, he has published almost 3 or 4 papers sitting on bioRxiv, and it's really challenging to finish those. You try to finish one and the other one is already up there with really interesting and novel findings in the field of bladder cancer. And Lars, probably you need to space these out a little bit more so we can digest the information before the next one comes up. Clearly, Dr. Dyrskjøt's group has published several high-impact papers over the last many years in the field of patient-oriented research in bladder cancer. The highlight being the establishment of the UROMOL cohort and its expansion, characterization, and several consequent projects that have evolved from that, that have improved our current state of understanding of bladder tumor heterogeneity, its classification, biomarkers of treatment response, and pretty much every bladder cancer researcher across the globe has benefited from this huge contribution. Without taking further time, I will now pass it on to Dr. Dyrskjøt, and probably he can tell you much more about his research.
Yeah, thank you very much for this kind introduction. So I'll try and go over some of the different results that we've published over the years. And as you can see here, the title of my talk is Tumor-centric and liquid biomarkers for guiding treatment decisions in bladder cancer. So I'm going to cover the field of tumor biomarkers in early stage bladder cancer and in muscle-invasive bladder cancer, and then talk about how we may be able to use liquid biopsies also as an alternative to this. So first of all, biomarkers, how can they be used? So we would like to identify diagnostic biomarkers for screening of high-risk populations and for surveillance after surgery or during follow-up. Prognostic biomarkers that can be used for risk-adapted surveillance programs in especially probably early-stage bladder cancer, and predictive biomarkers that may be probably the most important task, but also the most difficult task to look at for selection of optimal oncological treatment. I'm going to start with talking about non-muscle invasive bladder cancer and subtypes and prognostic biomarkers in this field. And with this, I would like to start with highlighting this paper here. It's almost 20 years ago now since we published this first paper using microarrays on 40 bladder tumors and identified different risk groups in this. And this is actually important paper for me that kickstarted my career in the bladder cancer field also. So here we identified these basically two different two different classes in early stage bladder cancer that was associated with aggressiveness. And we validated that. There was a CIS signature and progression signature that sort of covers the same area. And then we validated that in a retrospective study here of 294 patients. So basically here we identified 2 different risk groups, and these 2 risk groups were then further validated and identified and validated in the UROMOL study. So the UROMOL study was initiated in 2008 at 10 different clinical centers in Europe, where we included patients with early-stage bladder cancer into this program. And here we started with validating this risk signature for progression in early-stage bladder cancer. We had transferred this signature to the 12-gene risk score, as you can see here, different 12 genes here. All the tumors that were classified as a molecular high risk with progression signature, they are positioned here, and then the tumors from patients with a molecular low risk, they are positioned here. And here in this study here, we can see that it was associated with progression to muscle-invasive bladder cancer using different cutoffs that we identified early on. It was associated with progression, these different signatures with the different cutoff scores, as you see here. And if we stratify by UITC risk scores, if you only look at high-risk patients, it's still significant, the predictor here. The Lund team in Sweden, they had a different approach where they looked at the full continuum of bladder cancer. And basically in early stage bladder cancer here in 2012, they identified the 3 different subtypes of NMIBC. Importantly here in NMIBC, they could see the urobasal A tumors, genomically unstable, and infiltrated tumors were sort of dominating in this field. So now we started with 2, and now we're up to 3 different types that are sort of representative of early stage bladder tumors. We then continued in the UROMOL consortium on the same tumors that I mentioned before. We did the 12-gene risk score on. For this, we did a publication in 2016 where we identified also 3 different subtypes in NMIBC. And then we further characterized these tumors here in the publication in 2021, where we performed total RNA sequencing of 535 tumors in this study. What we found here was basically 4 different subtypes using consensus clustering in early stage bladder tumors, class 1, 2A, 2B, and 3. And what's characteristic about this is that we see that the class 1 and 3, they have an overexpression of FGFR3 co-expressed genes. Class 2A, that's a high-risk group, they have late cell cycle genes and DNA replication genes expressed. And importantly, the class 2B, they have a lot of different they have a high immune infiltration score. That's what we can see here also. If we look at the immune infiltration score generated from a deconvolution process of the RNA-seq, and we can see that this, especially class 2B, is associated with high immune infiltration score. If we look at progression-free survival for the UROMOL classes, we see that especially class 1 has a very good progression-free survival, while the class 2A patients, they have the worst survival here. We see the same tendency for recurrence-free survival, also where the class 1 has the best outcome, and class 2A and 2B has the worst and highest recurrence-free survival here. And this is actually significant also when we stratify for UITC risk scores. In the UROMOL study, we also looked at copy number alterations in MIBC, where we did a SNP arrays on 473 tumors. We used this data to divide the tumors into 3 different genomic classes based on the copy number alteration burden as a genomic class 1, 2, and 3, as you can see here, depending on the number of genomic alterations. If we look at the tumors from patients with the highest number of genomic alterations, the genomic class 3, you can see that these patients also have a poor progression-free survival here compared to the genomic class 1 and 2 here. And that's also reflected if we overlay this with the transcriptomic classes. We can see that the class 2A has the highest number of genomic class 3 also included. So this is truly an aggressive tumor subtype. We also did the validation of the UROMOL subtypes in the study from expression data from 1,300 independent tumors. And we developed this single sample classification transcriptomic classifier that you can access by using this link here. All the different tumors in the cohort were classified according to these different subtypes and the distribution, as you can see. And again, using this independent validation data set, we can see the class 2A has the worst progression-free survival compared to class 1 here. This is an overview of the different subtypes in the UROMOL classification system and the different biological characteristics in this. And here you can see that especially class 2A, they have a p53 altered pathway, RB1 mutations. They have a high ApoBec mutation score and have high heterogeneity also. It's interesting to compare this to class 2B, where we see a high immune cell infiltration, and we see high expression of, for instance, PD1 and PDL1 also, which led us to think that these patients may not benefit optimally for BCG treatment. It's only few patients in the UROMOL study that actually received an optimal BCG course. So these patients we see here, they represent patients that have received at least 5 cycles of BCG. And when we look at class 2A and 2B in these patients, we cannot really see a difference in this. So in this small study here, the UROMOL subtypes are not predicting response to BCG treatment, unfortunately. So moving on, we have looked further into this and looking at what then characterizes BCG response in MIBC. And we've done a retrospective study. We looked into our biobank and found how many patients we could identify that received at least 5 or 6 cycles of BCG treatment. Then we selected blood samples and tumor samples before, and in some cases after BCG treatment. We identified urine samples before and after BCG treatment. And we also looked into selected site biopsies taken before and after BCG treatment to identify field effect and how the field effect may affect the disease course. So we included 156 patients in this analysis, performed RNA sequencing on 211 tumors, did whole exome sequencing of 234 tumors and germlines, as you can see here. And then based on that, we designed a custom panel for sequencing urine samples and selected site biopsies deep based on the selection of clonal mutations. And we did this on 525 selected site biopsies taken throughout the disease courses and 150 urine samples. And then we performed some protein O-link analysis also on the urine samples as indicated here. In this study, we looked at BCG failure as early high-grade recurrence within the first 2 years after BCG treatment or progression to muscle-invasive disease. So first, what we did in the study was to look at the classification using the UROMOL classification system on the pre-BCG treated tumor and the post-BCG treated tumors in the cases where we had this one also. And you can see if on this side that most of the tumors were classified as the class 2A, indicating that they are high risk, and that makes perfectly sense also that these patients are high-risk NMIBC patients. So we should see an enrichment for this. But interestingly, when we then compare to what happens to the classification of the tumor after that may be present when they recur after BCG treatment, we can see that many of the patients with a class 2A initially, they recur as a class 2B tumor with a more infiltrated tumor subtype. So we looked more into this and looked at which markers were present in the patients that showed response to BCG treatment compared to non-responders. And here we can see that the different T-cell inhibitory markers, as you can see here, they were actually higher expressed in the patients that showed no response to BCG treatment. So looking further into this, we could look at these 5 different exhaustion subtypes. where we can see that if patients have a high-grade recurrence after BCG treatment, they have a higher level of these different markers here, indicating that the T cells are more exhausted compared to the patients that show no high-grade recurrence. So we looked a bit further into this and looked at developed an exhaustion score based on these five different markers, and then correlated that to the number of T cells also present in the tumors. And then based on this, we developed a T cell exhaustion score, as you can see here. And then we can see that this, when we look at this exhaustion score and compare to high-grade recurrence versus non-high-grade recurrence, we can see that there is a tendency to a higher level already before BCG treatment. But after BCG treatment, we can see that this exhaustion score is high in the patients that show high-grade recurrence. So this is our schematic view of this, that if they have a high T cell exhaustion after BCG treatment, then they may have a BCG failure from this. So we tried to, based on this data, we tried to develop a predictor or a signature of post-BCG exhaustion. When we did that, we developed this gene expression signature. And when we applied that to all the pre-BCG treated samples, then we can see that the low post-BCG exhaustion score, the patients here, they have a better high-grade recurrence-free survival compared to the patients with a high post-BCG exhaustion score. So this is only when looking at the tumors before treatment. And to validate this further, we had access to this data set from the Young et al., where we could validate this also, where again we showed a difference between the low and the high post-BCG exhaustion scores. We also looked at the urine, as I mentioned before, where we looked at different markers of exhaustion and other immune-related markers when we compared a urine sample taken before and after BCG treatment. If we look at all patients receiving BCG treatment here, all 156 patients, we can see we have a general activation of the immune system by expression of CXCL 9, 10, and 11 being present in the urine. But if we stratify this analysis to patients that are BCG responsive compared to patients with BCG failure, we can see that we have different exhaustion markers being present here in the urine also. For instance, CD1 also as PD1 marker. So this is interesting, indicating that the exhaustion score is actually associated with BCG failure. We also looked at urinary tumor DNA tumor-derived DNA levels pre and post BCG treatment. So here we used this panel that I mentioned before to sequence the urine samples really deep based on the clonal mutations from the whole exome sequencing. When we do this, we can see, if we compare the number of copies of mutated DNA in the urine, we can see that patients with BCG failure, they have a higher level of mutated DNA in the urine before treatment is started. So this could indicate that we have more field disease. The tumors could be shedding more, or it could be more invasive before the BCG treatment is initiated. And also, if we look at the dynamics here, we can see a ctDNA clearance. Compare before and after BCG treatment, we can see that the urinary tumor DNA levels in the urine, if there is a clearance, they have a better recurrence-free survival after BCG compared to if there is no clearance here. We did do another study also within this setting to look at field effect and these mutations in these clonal mutations in the tumors. How are they present in the selected site biopsies? Did this for 134 of the patients, and then we looked at the 664 normal appearing selected site biopsies. So it's based on whole exome sequencing. We select mutations between 10 and 71 mutations for each patient, and then we do really deep targeted sequencing of these patients. And then, because this is rather old FFPE material, we do some quite robust data filtering to avoid including too much noise in this, and then identify the true mutations in the selected site biopsies also. And based on this, we then build a model to tell us how pronounced is the cancerized field in these patients. And when we look at this, we can see that the patients with high cancerized field in the bladder, they actually have a higher recurrence-free survival, high-grade recurrence-free survival compared to the patients with a low field effect. We have looked a little bit more into this. If we look at the tumor mutation burden before BCG treatment, if the tumor mutation burden is higher, then it's associated with a higher cancerized field also, and that's the same with the neoantigen load, obviously. And interestingly, if we look at the pre-BCG field, we can actually see that if patients have a high cancerized field, they have a higher level of T-cell exhaustion in the tumor, also indicating that there may be some link between the mutations in the bladder and the level of exhaustion in the tumor also. So from this, I'm going to shift gears a little bit and move on to muscle-invasive bladder cancer and prognostic and predictive biomarkers in this field. A couple of years ago, this consensus subtype classification was published on muscle-invasive bladder cancer using 6 different subtypes with the different biological characteristics, as you can see here. This is the overall survival of the patients, and we can see the neuroendocrine-like patients with a neuroendocrine-like tumor. They have the worst outcome here, and they have basal squamous. They also have a poor survival, while the luminal tumors, they have a better survival. But the most important thing here may be to look into if these subtypes are associated with treatment response and response to neoadjuvant chemotherapy. So this is a selection of patients, 367 patients that received neoadjuvant chemotherapy in this study. And here we could actually see that there was no difference in survival for the patients with the different subtypes. And we could also see that there was no correlation to complete pathological response when we look at the different subtypes. We did another study a couple of years ago now on the chemotherapy response markers, where we included a total of 300 patients receiving both neoadjuvant and neoadjuvant chemotherapy and chemotherapy for metastatic disease. And in this multiomics study, we found that the mutation signature SBS5, BRCA2 mutations in the tumors, and a high level of indels and allelic imbalance was associated with a good response to treatment, while patients with the basal squamous subtype, the patients that had no immune cells present in the tumor and with a low PD-1 expression, they show a poor response. So based on this, we developed a 2-tier system here where we look at the genomic instability, high and low tumors. And then we can see how these different categories here that I just mentioned are associated with the genomic instability. And here we have the expression subtypes also. So what we did in this study was to make a sort of a 2nd-generation biomarker where we look at both the genomic instability and the subtypes also. So if patients in this study have a high genomic instability and a non-basal squamous subtype, they actually had a pretty high response rate here, indicated by the green color, compared to patients with a low genomic instability and a basal squamous subtype. They had a poor survival or a poor response to treatment. Of course, these are small numbers and it has to be validated in larger studies. We did this analysis here on a tissue microarray of more than 100 patients receiving chemotherapy also. And here we could identify that patients that showed response to, that's the blue color here, patients that show response to treatment, they had a high immune cell infiltration, and they also had they had a non-basal squamous subtype if they responded. So the basal subtype in this study here was also associated with a poor response to chemotherapy. There's not a really good consensus yet in the field in this area. So the Lund group, they have published a study on neoadjuvant chemotherapy and chemotherapy for metastatic disease also, where they show that the basal squamous subtype is also associated with a poor response to chemotherapy. There was a different observation in the Xyla et al. Study published in 2017, where they show that the basal subtypes is actually benefiting from neoadjuvant chemotherapy when comparing two different cohorts. But in this study, there was no correlation between subtypes and pathological response. And then again, in this study here, again, a survival benefit was seen in patients with a non-luminal subtype also. But overall, what we need to do in these studies is to include a consensus classification system and use that in the studies that we're doing, because here we are actually using different ways of measuring a basal squamous subtype, and that may affect our interpretation of this. So there's no consensus yet. If we look at immunotherapy efficacy, then we have some more strong data here. We see that the cytotoxic T-cells are associated with good complete response to treatment. Tumor mutation burden, high mutation burden is associated with response, and DNA damage response markers are also associated with response, while the TGF-beta pathway activity is associated with a poor response also. And then when comparing to different subtypes, the authors, Maria Tasson and colleagues here, found that the genomic unstable subtype was associated with a higher frequency of responders compared to the rest of the patients, probably driven by the high mutation burden in the genomic unstable subtype here. However, in the neoadjuvant setting and in different combos of treatment, as you can see here, there are really no consensus yet of predicting response or resistance to different IO strategies. There's been some inconsistent results in different studies, and this really indicates that we need to do more studies in these settings, and probably especially in the neoadjuvant studies. So why is this discrepancy we see here? It may be that it's because bladder cancer is a highly heterogeneous disease. We know that we see a lot of heterogeneity. This is from a study we published a couple of years ago now, or some years ago now, where we see a large heterogeneity within one single cystectomy specimen, also both on the mutational level here, where we see different subclones arising, and we also see that within this tumor we have both basal and luminal subtypes within the same tumor and the same patient. And we also have the evolution of different subclones over time, as you can see here, and the chemotherapy may actually drive resistance to different subtypes being present. So it may be that the tumor-centric strategy that we have been following so far is sort of have limitations because of the huge heterogeneity we're looking at, and maybe liquid biopsies for predicting the outcome of treatment response may be a better solution. So I'm going to shift gears now into this area and talk a little bit in the last part of this about circulating tumor DNA and what and how we may be able to use this, and especially muscle-invasive bladder cancer. So cell-free DNA is being shed into circulation from healthy tissue and from inflamed tissues, and in higher degrees also, and from neoplastic areas, neoplastic lesions. We see mutated DNA also being shed into circulation. The DNA, mutated DNA, is highly fragmented, only protected by the nucleosomes, it's degraded down to 150 base pairs approximately. And in bladder cancer, it's interesting that we can see it in the urine also from renal clearance. The half-life of cell-free DNA is below 2 hours. That means that we can use the mutated DNA in the plasma for actually monitoring the residual tumor burden, and that's especially interesting during different treatment forms and after radical surgery. The levels of circulating tumor DNA and cell-free DNA is associated with the tumor stage and tumor size, as you can see from these two graphs here, indicating that it may be difficult to actually have to identify tumor volumes below 1 cubic centimeter, also as indicated by this figure. ctDNA has a potential to be used throughout the disease course, from cancer, early cancer detection, screening, early diagnosis, to molecular profiling or prognostication just before surgery, for detection of residual disease after surgery, and for monitoring of treatment response using serial liquid biopsies, and for actually also monitoring of clonal evolution during treatment. It can be divided into two different approaches: a tumor agnostic approach, where we have no information about the specific patient's tumor and biology of the tumor. It makes it more difficult to identify and to identify few molecules from a cancer in this setting. And also, if we have a tumor-informed approach, where we know from surgery what kind of mutations that we're looking for, and we can use those for tracking the disease course, which makes it possible to detect even lower amounts of circulating tumor DNA. We did a study some years ago now on liquid biopsies taken during a diagnosis, during neoadjuvant chemotherapy, at cystectomy, and at different follow-up time points after cystectomy. 68 patients in total, and it was a collaboration with the Natera, where we used their approach with a deep sequencing of these 16 mutations obtained from whole exome sequencing of the tumors. This is one example what we see from this study, where we can see that this is the cystectomy time point, and this is neoadjuvant treatment. And here we see three positive blood tests for circulating tumor DNA during neoadjuvant chemotherapy, then dropping down to not detected before and after cystectomy, indicating that the neoadjuvant treatment was working. And then the patient becomes ctDNA positive again at this time point here. This is actually 245 days before detection on a CT scan, as indicated by this mark here. This is an overview of all the patients that are ctDNA negative in the study. All the white circles here are ctDNA negative tests, and the green lines are CT scan negative results. You can see that the ctDNA negative results are associated with very good outcome for these patients. Patients that are ctDNA positive have a poor outcome, as you can see here. Many of these patients, they have a CT scan positive result at these different purple lines here. And interestingly, in this graph here, we can see that actually many of the patients that become that will develop metastatic disease later on, they are ctDNA positive already at the first blood sample drawn from these patients before neoadjuvant chemotherapy. There are some cases also where the ctDNA they're ctDNA positive, and they have a particularly good outcome, also indicating that they may have been cured by chemotherapy or by the cystectomy also. So in this study, ctDNA is highly correlated to disease outcome. before chemotherapy is initiated, before the cystectomy, and after cystectomy, also indicated by these lines. But importantly, we see an average positive lead time of 3 months, making it possible maybe to initiate treatment for these patients at an earlier time point. I'd like to mention this other study that we've been doing, where we've been looking at the whole genome sequencing instead of a 16-plex assay. And the idea is that if we move from detection of one mutation in the plasma to detection of thousands of 10,000s of mutations in a plasma sample, we increase the probability of identifying ctDNA in a sample actually at not that high unique coverage also. So that means that we can maybe use 20 or 30 times coverage whole genome sequencing for identifying ctDNA in a plasma sample. So we've been collaborating with a company called C2I Genomics on this, where we built a model based on whole genome sequencing of the tumor and the germline, and then use this model to predict if the plasma sample is ctDNA positive based on this approach. So that means that we don't have to develop patient-specific assays each time, but we can just do a whole genome sequencing of all samples, making it easier to implement. It's also possible to use this on lower levels of lower volumes of plasma. These are the results from patients where we do whole genome sequencing of 20x coverage. All these patients have metastatic relapse later on, and we can see many of these present with a ctDNA positive result at an early time point here, as we saw for the other cohort I mentioned before. And these are patients that have a good outcome with no clinical relapse, and most of these are green and circulating tumor DNA negative. This is the recurrence-free survival for the patients in this cohort, and importantly here we increase the median positive lead time to 5.3 months compared to the 3 months in the other setting. We've also showed that we can use this for monitoring response during neoadjuvant chemotherapy. If we look at circulating tumor DNA levels measured before, during, and after neoadjuvant chemotherapy, we can see that in this case here, the levels drop to 0 here, and they are corresponding to the pathological downstaging that we see for these patients. Here we see that there is no pathological downstaging, and circulating tumor DNA levels are also high, while these patients show opposite results, where there's no pathological downstaging, but actually the circulating tumor DNA levels indicates that the treatment is working. So what is then best? If we compare to clinical outcome recurrence after cystectomy, we can see that the circulating tumor DNA dynamics actually outperforms the pathological downstaging in predicting recurrence after treatment, indicating that this may be a better tool for monitoring the efficacy of the treatment. It's been investigated in the adjuvant setting also by Tom Paulson and colleagues here in the Uyghur 010 trial that did not reach the primary endpoint, but after analyzing this further, they could see that if they just looked at patients that were circulating tumor DNA positive, they could see that the patients receiving atezolizumab, they actually had a survival benefit compared to the observation group. And this was also the case when they looked at the reduction of circulating tumor DNA, reduction with clearance. They had a high probability of recurrence-free survival, while if they had no clearance or increase of circulating tumor DNA during treatment, they had a poor survival and outcome. So right now there are different trials ongoing for evaluating the power of circulating tumor DNA guided treatment in the adjuvant setting. We have the Uyghur 011 trial ongoing. That's circulating tumor DNA positive patients that are randomized to atezolizumab versus placebo, and the primary endpoint here is disease-free survival in patients who are ctDNA positive. And here in Denmark, we have the Tombola trial that's circulating tumor DNA positive patients receive atezolizumab. This is a non-randomized trial where the primary endpoint is complete response, defined as circulating tumor DNA negative status combined with a normal imaging after treatment. This is an overview of the Tumor trial, and what we do, it's 5 different centers here in Denmark where we collaborate on, including the approximately 280 patients that need to go into this trial. And we take all these blood samples during neoadjuvant chemotherapy and at this frequency after cystectomy. And if they're circulating tumor DNA positive here after cystectomy, they will receive atezolizumab at this visit, disregarding the status of the CT scan. And here we then have a window to develop the different patient-specific assays for the patients while the patients receive neoadjuvant chemotherapy. So the take-home message here from me today is that if we look at the tumor-centric biomarkers, the subtypes can be used as a biological framework for identifying novel biomarkers. Subtypes are prognostic in MIBC and muscle-invasive bladder cancer. The T-cell exhaustion may be a predictive biomarker in non-muscle invasive bladder cancer. It has to be investigated further. And for predictive biomarkers in muscle invasive bladder cancer, there's really no consensus yet on this. Liquid biomarkers circulating tumor DNA has a potential for being used as risk assessment before treatment and cystectomy for early diagnosis of minimal residual disease after radical cystectomy and for monitoring response during chemo and or immunotherapy. So what we need to demonstrate now is the clinical impact of these biomarkers in biomarker-guided clinical trials to demonstrate that we can actually improve survival and can we improve quality of life for the patients, and can we reduce the costs to society. And hopefully in the future we can have a 2-tier approach here where we have a tumor-centric biomarkers and also liquid biomarkers, and then have a combined analysis of the tumor and blood or urine to make a better risk assessment of the patients to guide treatment in a better fashion. So with that, I'd like to thank you for your attention. I would like to thank my team here, collaborators, and the different funding agencies that have supported this. So thank you for your attention.
That was a fantastic talk, Lars, and very exciting findings. I mean, it covers the entire spectrum of bladder cancer and starting from subtyping to ctDNA, which seems to be super exciting, how it can predict response. And the lead time, 5.3 months, that is amazing, amazing for bladder cancer patients. So I'll open the floor now for the questions, and I would really like trainees to ask questions before we pass it on to faculty. Any questions